Hello, everyone. My name is Muhammad Alsayid, and I'm one of the members of the Education Committee at Syrian American Medical Society. And here we have our third episode of Exploring Pathways of Medical Specialties. This is a series that we just started about 3 weeks ago, and our goal is to help medical students and medical residents who are in training to explore the different pathways of specialties. And we would like to introduce these specialties to them so they can think about pursuing them in the future, and also to introduce our guests. And also our guest will help us to understand those specialties, and they will give us also advice and tips about those specialties. I would like to welcome Dr. Bassel Atassi for the third episode in this series. And he is a graduate of Jordan University of Science and Technology. He did a research fellowship at Northwestern University, Chicago, in Interventional Oncology Department. He did his internal medicine residency at the Advocate Christ Hospital, University of Illinois in Chicago. And his hematology oncology fellowship was at Karmanos Cancer Institute, Wayne State University. He's currently a clinical assistant professor at the Chicago Medical School and Rosalind Franklin University, and he is the director subspecialists of the medical group Little Company of Mary Hospital, Evergreen Park in Illinois. He is also one of the members of the Syrian American Medical Society, and he is now the chair of Hematology Oncology Committee at SAMS. I would like to welcome you, Dr. Bassel, and I want to thank you so much for coming to this episode and helping us understand more about hematology and oncology specialty.
Thank you, Muhammad, and thank you for having me.
Thank you. I would like to start with the first question, and usually I ask my guests to tell me about themselves, but this time I would like to start with a different question. I want to ask you, what motivated you to pursue your medical training in the United States?
Okay, Muhammad, thank you very much for having me again, and thank you very much for this great series of educational activities. Always SAMS and SAMS Educational Committee, they come with great ideas and initiatives, and they help the generations understand better about medical training in U.S. and about different aspects in education. So thank you again. What motivated me to come to U.S.? Probably many reasons, and most of the people who come from overseas, a foreign graduate, they probably share most of these reasons to come here, which is basically better education, lifestyle. They try to probably adopt a new system of education in U.S. compared to what they have in their back homes. They try to improve themselves so they can provide better care and medicine for their homelands. As well as personally, I had and I still have family in U.S. and I have dreams to come to U.S. since I was in even before medical school. So these are the main reasons for me to come to U.S.
So why did you choose hematology oncology as a specialty?
Great question, Muhammad. I think I'm gonna tell you in general the path how medical students and residents find themselves as pursuing hematology oncology, like many different reasons, and then I will tell you about my personal story. Many medical students and residents, they pursue hematology oncology. For example, main examples are, for example, they got inspired by a teacher or a physician or basically oncologist during their medical training in medical school or residency, and they got inspired by the teacher, but by his patient care, by certain stories of some patients who they have successful cure of cancer, or they have a challenging. Most of the hematology and oncology patients are challenging, so they like the challenging part of this specialty, and also other reasons why people they pursue this specialty is a family member. They tell you family member they have, or a loved person they do have in the family, or a friend. They had cancer and they wanted to get treatment options for them, or they get cure options for them in the future. The other reason is why people they like this specialty is the research aspect. Many medical students and residents they would like to stay in academic places and do research. And oncology and hematology, one of the most innovative medicine specialty that people they can have research options in. And the other also reason that I would like to highlight on is the social aspect of this specialty. This specialty needed a person who to be social, who like to have family discussions, family meetings. This specialty different from none from other specialties. They have a lot of procedures. There's no procedure in this specialty, but the procedure is your personality, how you present the case, how you're able to present bad news to the patients, how critical news to the family, and how to deal with it, and how you're able to counsel them in a nice social way. So this is one of the aspects of personality. People they like this specialty to be able to do all these things. My personal story, why I like this, is probably a combination between different aspects what I mentioned. But personally, I was inspired by a few of my teachers during research and residency, and I like how the way where dealing with patients and delivering the news and cure patients, as well as a family member who I had that they have a cancer case, and I wanted to be a cancer doctor to be able to treat a person like my family member in the future.
Yeah, it's always hard actually to have a family member who has this disease, and especially if treatment options are limited. However, nowadays, I'm sure that the treatment options now are actually evolving every day, and we hear about a new chemotherapy, new immunotherapy, and different types of treatment plans that's going into effect. And I think that's what you mentioned, that this is one of the aspects that you like about hematology oncology, the ongoing research in that field. In pursuing your medical career in the United States, can you describe maybe some of the challenges that you faced that you faced during your medical training or during your life here in the United States to get where you at now?
Absolutely. So as a foreign graduate, I mean, my story again, maybe similar to many other stories, that when you come and you compete in the U.S. Medical system, you have to have very good scores. You have to compete with people who are U.S. graduates. You compete with people who have great CVs from their time of college and then time of the medical student until they can graduate, and you become with them applicant in residency. You have to compete with people who are coming from uh, countries from different backgrounds and different very high qualified people. So these are one of the challenges, that you have to have good scores, you have to have good CV, you have to have good personality, you have to have good personal skills and characteristics that allow you to be able to take the challenge and be a member of this medical society in US. Personal challenge is me as a coming from overseas was number one to be improved in language. Number two is to improve in communication skills. A lot of times in the foreign medical schools, they don't teach you enough about communication skills, or don't teach you enough about how to deal with your peers or your higher people or teachers, or even sometimes difficult to deal with different patients. So this was one of my challenges. After I entered my research fellowship, I went to residency, and one of the challenge in residency is to be able to integrate it with different backgrounds of different residents, different people from different educational backgrounds. And then the big challenge is for me after residency to be able to pursue subspecialty, which is the most of us know that a lot of people they apply for subspecialty, and it's not easy to get. So you have to work great on yourself, on your CV, on your research, on your publications, to be able to guarantee fellowship. So I did my best to be able to have a good CV. So when I applied for fellowship, to be able to guarantee a fellowship. So all these things are challenges, and of course we have every one of us has many other challenges that we dealt with during residency and fellowship.
Definitely, yeah. So, what do you think that the main factors that helped you to secure a fellowship position in hematology oncology?
The main factor that I had great in my resume and what making my CV strong is the research fellowship I did before residency. I did about a year and a half of research fellowship, and I ended up having good experience in research and have about 17 publications. When I applied to fellowship from my residency time, we used to apply in our second year. So when I applied to fellowship, I was probably one of the highest ranked people in number of publications and number of years of research, as well as I had was strong in my CV, which is basically when you do research, they always care about which study or article or publication you have as a first or last author. And this is a note for all our listeners that great to have research, is excellent to have publications. Try your best to be the primary person who do the study and do the article and write your study so you can be at least first author or second author, and it will be great if you are last author, which is basically the kind of godfather of the whole study is usually the last author.
So, from what I hear from you, that research is one of the main factors that applicants need to have on their CV when they apply to hematology, oncology, and they can do this research before they start residency or during residency. Like, if you want to give an advice to a medical student or a resident um, who is looking for applying to hematology, oncology, what kind of advice and what are the tips that you want to provide them other than doing research?
Great. The main advice I have for people who have some interest in hematology oncology, especially medical students, and mainly when they go to residency, that when you go to your medical school and you do your medical internal medicine training, and when you do your internal medicine training, when you do your hematology oncology rotation, this rotation usually does not represent hematology oncology. Hematology oncology is primarily, mainly outpatient. A lot of programs and medical students, they do inpatient type of rotation in hematology oncology. And basically the inpatient probably represent about 10 to 15% of what heme onc is. And I see that a lot of people, they shy away from this specialty just because of this rotation in inpatient, which basically in the inpatient you see patients who are even end stage, or people who have complications from treatment, people who have new diagnoses, people who got sick from treatment and now they have family meetings about complications, or patients sometimes who are need palliative care or hospice care discussion, people who have nausea, vomiting, diarrhea, examples, or people have issues from the cancer itself or from the treatment itself. This does not represent what hematology oncology is. What hematology oncology is, mainly outpatient. When you see people who have cured from their cancer, when you see people who you do your treatment, and then after a few months you see the results of great response. When you see people who are challenging all the other specialists or the internal medicine colleagues send you a challenging patient for you to solve and work on. It's outpatient is when you see somebody who is, let's say, 5 years post-treatment or 10 years on hormone treatment because she's doing great on her breast cancer, or somebody who has lymphoma 20 years ago. So this is what represents what hematology oncology. It represents good responses, cures, as well as always challenging and great stories of people that you see. And this is, in my practice, and most practices, represent about 80% of the cases. Unfortunately, many of the rotations, they do their rotation in inpatient, Many of the hospitals, they do rotation inpatient, which it does not represent what Heme-Onc is. And I can tell you stories on and on of successes and cures and moments with the patients and their families about how they do and how the cancer get better. And even honestly, Muhammad, honestly, when you have somebody with stage 4 disease, you can work with them in the outpatient on improve their symptoms, or improve their activities. They can survive with treatment, or even sometimes without treatment. For sometimes they're comfortable, which is this is what the unique thing about this specialty, that also you become part of the family. If you see how we practice in outpatient, the cancer centers, a lot of times when our patients come to the hospital, the whole family know who you are, the whole family appreciate you, the whole family, you become part of them, and they become part of you. And this is what I mentioned initially about the social aspect of this specialty. This is what the beauty of this type of medical practice. And as I said from the beginning, to be able to do all this, you have to like it. You have to like it. You have to be this. You have to be part of this kind of work, daily work that we do in this specialty. And this is what I said to my colleagues and sometimes my medical student, that the uniqueness of this specialty is everything else. Everything I just mentioned, of the good stories and the social aspect and so forth.
Yeah, I actually I still remember my hematology oncology rotation during residency, and as you said, if someone spends the rotation in the inpatient service, then they will not learn what hematology oncology is. However, I was lucky and I did my rotation with. A hematologist oncologist who's from Harvard, and I did the whole rotation as outpatient, and I was going to the clinic every day, and I spent actually 4 or 4 days and a half every week in the outpatient settings, and I actually liked it. I was able to connect with patients, and I think that's what as you suggested, that most residents and medical students they need to do. They need to see the outpatient settings, because that's where you see the success stories, and you see those people who come after 4 or 5 years of treatment, and they are all happy. And of course, in the same time, you want to see those people who are newly diagnosed, and you offer them counseling. So
And
talking,
also,
yeah.
um, yeah, Muhammad, also to answer your question, the other question, that what my advice to medical students and residents to guarantee or to have high chance in getting this specialty, other than research, is, I mean, you do research in your pre-residency if you can, in your medical school if you can, and if you would like to get for HEMONC, you have to do research in your residency 3 years. Probably not advised in the first year because you're going to be very busy. You have no time to do all these things, at least in your second year and mainly in your third year. Now, people, they try to do this research, they get 1 or 2 publications, which is good in their CV. What I've seen also, and this is also another thing in this specialty, that some people after residency 3 years in internal medicine, what things increase their chances to get Hem-Onc fellowship is this 1 or 2 years, that clinical fellowship in one of the Hem-Onc subspecialties. There's a lot of hospitals that what they do, they have 1 year leukemia training. So you do only leukemia. That's not only for Hem-Onc fellows to be subspecialized. No, this can be also before fellowship. 1 year of GI cancers. I've seen people, they do 1 year, like hospitalists in a big academic program when they join, and they help them with the GI cancers. This is non-accredited. They do also sometimes 1 or 2 years in one of the big hospitals. I know MD Anderson, for example, they take every year 8 to 10 internal medicine graduates. They make them hospitalists in their big cancer center. There's also transplant fellowship, like 1 year or sub fellowship, that people they can some experience and they do it. And this I've seen in my friends and my colleagues increase significantly the chance of getting Hem-Onc. So if you'd like to get Hem-Onc, you can try from your residency to apply in your third year. If you don't get it, or if you don't wait more, you can do either hospitalist in one of the big cancer centers. You can do 1 year non-accredited fellowship, and also you can take 1 year to do research and so forth. For example, I mentioned one or I mentioned few of the example of sub fellowship in hemonc like leukemia, transplant, GI, but basically right now these days every single hemonc sub fellowship there is 1 year non-accredited. Sometimes you can do blood transfusion or blood bank we call it. Sometimes you can do breast cancer 1 year experience and so forth. Thoracic oncology, uro-oncology, all these things you can do for 1 year to gain more experience and increase your chances to do hem-onc fellowship.
Yeah, actually, that's actually very helpful because, as you said, there are few people. I'm sorry, many people actually they are doing this now. That they work as hospitalists in big cancer centers, and then they can get research, they can get connections, and at the same time they can get letters of recommendations from the specialists. So that's going to make it easier for them to get hematology oncology specialty. So you were telling me that most of the hematology oncology specialty is outpatient. So can you walk me through a typical day at your work?
For sure. So my work basically is a community practice hematology oncology. In hem-onc, you can specialize in one entity of hem-onc. For example, you can do only thoracic oncology. Usually this is big academic tertiary centers. They have 20 oncologists and 10 hematologists, for example. Every one of them is specialized. We have in our fellowship, for example, we have 2 people, they only do lung cancer. We have few people, they only do leukemia. We have 1 person does only do lymphomas. Because they have enough patients to be referred internally, and they can make them busy to see only one type of cancers. We have 1 person or more than 1 person, they only do benign hematology. And we have 1 person used to do only thrombosis and bleeding, like thrombophilia and things like this. We have 1 person who does multiple myeloma. So practice in hematology oncology is different from academic to private practice to community practice. For example, my work as in the community / private practice is you see most of the cancers, most of the type. And when you have difficulties or you have treatment that you don't have or certain subspecialty surgery, or you have to do transplant, or you have to do some acute leukemias, then you refer them to tertiary centers. So my work in the practice, like in the community, is usually outpatient. We have 4 days a week clinic. We have 1 day no clinic. We call it academic day. And in the 4 days clinic, they schedule patient for you from the morning 8:30, 9 o'clock until usually 2 o'clock, and depends of how many patient, how many day, how many we have scheduled patient, how many new, how many old. Between 6 to 7, sometimes could be up to 14, 15 patients a day. And then after that, you have to go and do the inpatients. Inpatients, you get consults, you get follow-ups every day, you get questions from ER, all these things. Some other doctors, they do vice versa. They start in the morning, like 8 o'clock or 7 o'clock, inpatient rounds. They go to the hospital, they see their inpatient consult and follow-ups, and by 11 or noon time, they go to their offices, and from noon till 4 or 5, whenever they're done, they finish the outpatient. And the other unique thing in our specialty is we have attached our cancer clinic as a cancer center, or attached to our hospital is the chemotherapy. We call it infusion area. That's why I call it my hospital. So we also have in the daily basis, in addition to the inpatient consult and follow-up, and the outpatients, new patients and follow-up, we have the chemotherapy patients that we see every day, and we round on them, and we see their families, and we talk about the plan, and we talk about any possible side effect or complication or dose changes or all these things. So between outpatient to inpatient to chemotherapy, this is how we usually spend our daily basis work in mainly community practice. Some people, they're more busy than other people. They do rounds later at the evening time. And if I want to tell you about the academic places or the tertiary centers, how they have the daily basis work schedule, usually they have less clinics and more kind of academic time. They have time for lectures, like sometimes daily lectures, weekly grand rounds, weekly they have something called journal club, and every week they discuss the major articles or research advances and so forth. And they have maybe 2 or 3 times clinic a week, and the rest of the week in research and meetings and writing papers and so forth, and teaching the fellows and the medical students and the residents. This is how in academic how they do the daily basis. We have something also unique in our specialty, is we have something called Tumor Board, which is basically a meeting when all the cancer specialists in the hospital, they meet and they discuss different difficult cases, challenging cases, cases they can share with the other specialties. And this tumor board usually include oncologists and hematologists and radiation oncologists, and they include radiologists, pathologists, surgeons, and so forth. Every tumor board for every cancer is different who attended and how many people attended. In big institutions, academic places, therefore every specialty, subspecialty in hem-onc, they have tumor board. For example, lymphoma tumor board, or leukemia tumor board, or thoracic lung cancer tumor board, because they have a very busy usually practices. Like breast cancer tumor board, sometimes they do it once a month or twice a month or every week, what used to be in my fellowship. In community practice, usually we have one weekly tumor board, sometimes twice weekly tumor board, to discuss all difficult cases in different specialty and subspecialty. We put the breast cancer patients, we put the lung cancer, lymphomas in one tumor board. We always meet and we discuss the cases. So this is what our daily basis, and we sometimes in academic, in community practices, when you have medical students, you also spend time of your day teaching the students who they shadow you and they take care of patients with you. And of course, one more thing to add, Muhammad, my daily basis, which is what most of the doctors in US right now, is we spend enough time in our day these days on the computer system, in the EMRs, and doing doing our notes,
Charting.
which is very time consuming. Sometimes you spend 4 or 5 hours seeing patients, other 4 or 5 hours just to document, which is also a big part of our day. And us in oncology, it's not enough just to tell them a couple of words to the primary care or to these other specialists. You have to detail your note. We have usually detailed note about the past, the present, and the future plans, and so forth. So our notes also usually takes time, at least 10 minutes, sometime more if new patient.
Yeah, this is also a challenge for of course for hematology, oncology, and for all the new coming interns, is how they spend their time. If they spend their time with a patient or they spend it with EMR, and they keep doing charting the whole day and they don't even finish on time. And yeah, of course, that's going to be a very interesting topic to talk about in the future. I would like to ask the attendees, if you have any questions, please write them at the questions section, so we can go through them one by one. And I would like to ask you, Dr. Bassel, so you mentioned that you work in a community/private practice. Why did you choose this route?
Okay, this is actually a great question, Muhammad, and maybe different people have different opinion about this type of this question. In academic places, usually the choice are limited. For example, I stay in Chicagoland area. You have 4 or 5 big academic tertiary centers. At the same time, you probably have 50 other community hospitals around Chicagoland area, and this is the same thing in every city and every big state. My choice was probably less competitive. This one of the probably minor reasons. The major reason is because I did not want to just like become only one subspecialist in one type of cancer or one type of hematology. I wanted to treat all kind of comers and all kind of patients. I wanted to be in more communication with the community. Um, I did enough research as a 1 year and a half, and I did a good number of publications at my research and after my research. And I wanted to do more clinical, less the research, less time on writing papers and do academic lectures. I wanted to do more time patient care and clinical work. Other reason is because like in the area that I live, all the big hospitals are in downtown, and this is maybe personal reason. There's a lot of traffic and difficulties compared to empty street and open street in the suburbs and the less suburban areas, for example, in Chicago or Detroit or other big cities. So many reasons. One of the also reasons, to be honest with you, and honest with all the attendee and listeners, that the finance part is also important. I don't have much details about finance part of how much academic oncologists and hematologists they make, but we know that mostly in academic, the salaries and the income probably less than people who do private practice, who they do community. So this is one of the reasons also why people they choose to be in the community and less to be in the academic. Although I have a lot of good friends and great colleagues from fellowship, they're doing great in academia and they have their name published in many things, and this is their passion, which is what I like, and this is they chose this specialty to be able to do more research and to do more discoveries and all the phase 1 and phase 2 and phase 3 clinical trials. This is their passion, which is I applaud them to do it, and they don't care about the other aspect that, like for example, I cared about. So different people are different, but this were my reasons why I chose to be in community practice.
Thank you, really. Thank you very much for sharing your experience and your thoughts about hematology oncology specialty. I would like to start with the first questions from our attendees. It says, how important are the USMLE scores for screening applications for interviews?
Great question. Is somehow important, is not as important as residency. I tell you, in my residency, they screen people and they filter the application based on scores more than anything else. Of course, you have to have other good criteria in your CV, but they screen the score before they try to invite people. In fellowship is less important because they screen people more about their recommendation letters, about their experiences, about research, about publications, about if they have done rotation in the same hospital they're applying for fellowship in. So they know the person and they have experienced them and they work with them in the same oncology or hematology rotation, so they know them. So basically, the scores are important, but less important than residency. And I known people that they don't have the very high 3 digits or over 250 or over 240, and they got into the Hem-Onc fellowship because of the other aspect that they work on, and especially good recommendation letters and also good research and good number of publications if they can.
So that leads us actually to the second question. Do case reports help for HEMONC fellowship?
There are degrees for the type of publications somebody and studies and research someone can do. Case report can be in the bottom, and basically to be realistic, a lot of residents or medical students they can only do case reports, especially in their medical student time and the first year residency. But then in your second and third year, when you join, when you do your rotations with somebody in academia or you do a rotation in somebody who was interested in hem-onc, you should have more than just case reports. Honestly, if I have somebody applicant with case report only, and I have someone else who's his name in a randomized, big, known, good clinical trial with experience, and his name is advanced, and he does a lot of work, and I ask him questions in the interview about the study and his well knowledge about research, I will take the other person with the research and randomized trial more than the person who has 5 or 6 or 10 case reports. So they're somehow important. They're better than no case reports or no publications, but do your best if you apply for HemOnc to have more than just case reports, clinical series, review articles, if you have your name in randomized big trials, even like small phase 1, small phase 2 trials. This is actually a big advantage in your CV.
I would like to thank you again, Dr. Bassel, for answering all these questions. And I want to thank you for joining us today. We really enjoyed talking to you. And I'm sure the attendees also benefited a lot from your experience. I want to thank you for sharing your stories and your experience in HEMONC Fellowship and Specialty. I would like to ask you if you have any final words, and then we can conclude our episode.
Okay, Muhammad, thank you again for inviting me and having me in this episode. My advice to medical students and residents who think that they would like to pursue HemOnc as a specialty, as a career in the future is, as I said, number one, not to take the whole impression about the specialty from an inpatient rotation to do more outpatient. I also advise them to ask their colleagues about the experience. I would like to make sure that they like uh, to be a social person, somebody who enjoy counseling, someone who enjoy family meetings, someone who doesn't scared or fear gathering or public speeches. These are very important things that you have to be able to do a good hem-onc work and to be able to do good patient care and counseling and be a likable hem-onc person. You have to like these things. I would like also to advise them to do their best to be able to match in hem-onc, to do research, to join big academic centers if they can, to do, if they can do during the residency enough research and they apply to hem-onc, they don't get hem-onc fellowship, to do this 1 or 2 years of subspecialty, or at least to do a hospitalist job for 1 or 2 years in a big known cancer centers, academic places, that they can at least take recommendations and get exposed to these kind of patients, so they make sure they like this kind of work. I would like to advise also foreign graduates that this specialty is pretty unique in a way that every day we see advances. I can tell you, Muhammad, that now I'm 5 years since I finished my fellowship, and probably 40 to 50% what I practice right now, I did not even learn in my fellowship. All this new, you mentioned immunotherapy, targeted agents, genetic profiling, all this, we call it targeted treatment for every patient is different. This is all like every day we see new things. Every week, every 2 weeks, there are new FDA approval. I counted in 2017, I think there was about 35 FDA approval of new drugs in hematology oncology. So this is one of the things that make sure if you apply to hem-onc that you like this aspect of evolving type of medicine, evolving type of specialty that you always have to read, always have to keep follow up, attend meetings, and receive emails about FDA approvals and new trials and new treatment options for your patient. If you like procedures, I don't think this is the good specialty for you. This is no procedure. We do bone marrow biopsy. This is the most we do. And I have known many colleagues and friends because of busy work, they send all the hemonc biopsy to their IR or like the PA or NP do the hemonc upfront. They do the bone marrow biopsy. So if you like procedures, this is not the specialty that you should pursue. You can probably go to cardiology or surgeries, or they go to GI and so forth. So these are general advices for people who are applying for this specialty. And I was saying about the foreign graduate, do your best. And one of the also unique things personally I like about my specialty is, given that I'm originally from overseas, from Syria, and I go often to visit countries like Turkey and Jordan and Lebanon. There is big need for this specialty from foreign graduates. There's big need in the homeland countries that we're from for this specialty. There's big lag between what we practice in US and what they have options overseas. So always I advise for foreign graduates to pursue this, so they can give advices and give treatment plans and help their colleagues overseas to improve their specialty and improve patient care. So this is what I have, and I hope that people who benefit from the talk and anyone has any questions, I will be more than happy personally to respond at any time.
Uh, Great advice. Thank you so much, Dr. Bassel, for joining us today in this episode. I'm sure everybody learned a lot about hematology oncology. And at the end of this episode, I would like to let you know that our next episode will be next week about gastroenterology, and we will talk about that specialty and how to pursue it as a fellowship. And thank you very much for attending this episode, and have a good night.